Good afternoon, and thank you, Mr. Chairman, Mr. President. Thank you, Professor Bagliadini, for this kind invitation. The topic that we will share this afternoon is the cochlear implantation in malformation. All of us knows that the cochlear implantation is a safe, effective procedure in deaf children with a normal cochlea. The challenge for the surgeon, but also for all the key radiologists, speech therapists, and the other people in the team is to perform cochlear implantation in children with cochlear malformation. We know that the cochlear malformation is more frequent in unilateral, in single-side deafness, than in bilateral deafness, but the incidence of the malformation of the inner ear in the bilateral deafness is about 20%. In the classification that we all of us use is the classification by Senarologo, and mostly 78% of the malformation is malformation of the inner ear, the vestibular part, the cochlear part of the ear. It is a deaf child. There are some other malformation of the middle ear, the windows, external ear, but the topic of our talk is about the malformation of inner ear. The classification of Senarologo, all of us knows that we have the very important malformation, just like labyrinthine aplasia, cochlear aplasia, concavity, incomplete partition of 1, 2, 3, in which the cochlea is a normal dimension, and the cochlear hypoplasia type 1, 2, 3, and large vestibular aqueduct. To plan the management of the surgery in the malformation is start with a very important planning of the imaging. The imaging with the CT scan and MRI, it's important to evaluate the kind of malformation and to evaluate the type of electrode you can use in that kind of malformation, the possibility complication that you can have during the surgery. For example, in partition type 1, in complete partition type 3, the most frequent complication is the gusher. So you have to choose a specific electrode that you can close the cochleostomy to avoid the gusher, to avoid the infection in the patient after the surgery. You do, in our experience, we use in most cases the Medel cochlear implants because the portfolio is very large. We can have the right electrode for each kind of malformation. So in complete aplasia of the labyrinth, of course, in this case, you could have also a bilateral aplasia of the nerve. This is the only case in which you can't have cochlear implantation. There is an absolute contraindication in that case. The only possibility in that case is the ABI. But the most frequent in the aplasia, of course, the cochlea, also this is an absolute contraindication. You can't, the cochlear implant is impossible, and the only solution, also in this case, is the ABI. What about the other kind of malformation? One malformation is there is not very frequent, it's concavity. In this case, you can have a special surgical technique because you can insert the electrode by the semicirculateral canal. In this case, it's very important to perform also the CT scan after surgery, and in some cases you use also a system by to evaluate the position of the electrode before, and to evaluate the dimension of the cochlea before. We use the autoplan system that you know is a system by the Medel, in which we can, with this system, with this software, we can calculate the dimension of the electrode and the position of the electrode. Also important to evaluate the results after the implantation. In this case, you can perform a CT scan, but in children it's not useful CT scan because you need a lot of X-ray radiation for the children. You use a normal radiography, a Stanvers, and with this system you can using a special software, we can, after the implantation, evaluate the anatomy fitting of the patient. So this is important for the radiologist to evaluate the position and the contact of the electrode with the wall of the cochlea. In terms of partition type 1, in this case we have no modulus, no interscala septa. Cochlea looks like a cystic structure. Vestibule is dilated, rarely a large vestibular aqueduct. There is a defect between cochlea and internal canal. We just told before that in this case you have for sure gush, so you have to plan your surgery considering this situation, and we can use, you have to seal the cochleostomy very precise, because if you don't perform this technique, you have a gush after surgery. It's possible to have a meningitis, as you know. Partition, in complete partition type 2 is the best, maybe from the point of view of the results of the incomplete partition. This is in this partition, the results, the outcomes are very good. In this case, we have normal basal tan, normal ganglion cells, and you can use a standard electrode. In complete partition type 3, you know that this is a X-linked deafness. There is the interscala septum, there is no modulus. The cochlea places at the lateral end of internal canal. The cochlea has a normal external dimension. You can use cochlear implant with complete wings. You can also in this case you can have a gash. Also in this case you have to use some electrode with a special kind of electrode, just a cork electrode we use to seal the cochleostomy to avoid the gash after the surgery. Other kind of intubation is connected with the hypoplasia of the cochlea, type 1, type 2, and type 3. In type 1, round or wide or void, but like cochlea rising from internal canal. Internal K2 is severely deformed. Modulus interscala septa cannot be identified. The dimension of the cochlea are less than normal. You must use a short electrode, of course, because the cochlea is small. In hypoplasia type 2, cystic hypoplastic cochlea, the cochlea has smaller dimension, defective modulus and interscala septa, a normal external outline, complete absence of modulus possible creating, wide connection with the internal ear canal, cochlear implant is placed in internal ear canal, that's a very high risk, a large vestibular aqueduct, vestibular minimal dilated, a defective stapes foot plate. Maybe have, in this case, maybe we have a recurrent meningitis. Hypoplasia type 3, the cochlea with less than 2 turns, cochlea has fewer turns, a short modulus, the length of the interscala septa is reduced, the internal modulus and interscala septa and the external outline are similar to a normal cochlea, just fewer turns and smaller dimension. The vestibular and the cochlear semicircular canal are hypoplastic. And the end, hypoplasia type 4, the cochlea with hypoplastic middle and apical turns, normal basal turns, but the middle and apical turns are severely hypoplastic and located more anteriorly and medially, not in normal central position. The labyrinth position of the facial nerve is located anterior and above the cochlea, rather than in its normal position posterior to the cochlea. So what are the clinical consequences of this situation? Choice of cochlear implant electrode, facial recess approach for cochlear implant placement is possible. You have to study, so before with an assessment, a radiologic assessment, position of the nerve, in this case is possible the complication, gash in 40% of case, chest fistula and meningitis, and that could be a problem for high mortality and morbidity. There are some confirmation of the posterior labyrinth, and 62% per 100 temporal bone malformation. You can have a malformation of lateral semicircular canal, vestibule, vestibular aqueduct, and semicircular posterior canal. The most frequent malformation is the lateral semicircular canal. This is the most frequent malformation, it's just that, and in this case you have to evaluate the anatomy before the surgery. The charge association is a malformation. You know, sometimes we have aplasia of the semicircular canal. All in this case, sometimes there is the absence of large semicircular canal, so during the surgery you don't have any normal anatomy, so it's a challenge for the surgeon. The vestibular aqueduct malformation, most frequent in ear malformation, abnormal when more than 1.5 millimeter, when then post-semicircular canal. 60% have associated anomalies of the semicircular canal, cochlea, and vestibule. The remaining 40% is normal on CT scan and MRI. So, I think that's important to evaluate the outcomes in the form of the cochlea. It could be useful to use a objective measurement of the cortical potential in children. Most of these children, of course, are very young. We perform the surgery under the age of 1, so it's very difficult to evaluate after the surgery the results. Children with inner ear malformation are significant. We told about 20%. No cortical potential data published in children with the cochlear malformation. Hypothesis is the cortical potential from children with the cochlear malformation would be different from children with normal cochlea. The reason is a different brain paths way may be triggered due to the different tonotopicity, adulterate synchronism of nerve fibers with electrical stimulation. This is the hypothesis of the study. The methods: direct electrical stimulation with the clinical software Maestro, 90% of MCL from fitting map OS RT level, 1 medial electrode, 90 emission bars at 0.9 kHz. The children were most older than 6 months with the use of more 10 activity electrodes. AP recording device. This is the system that we use by Medel for evaluation of the cortical potential. It is the results. 14 children, 11 bilateral, 25 years, 2 groups, 9 normal cochlea, 5 cochlear malformation. Mean age 8.4 years, mean duration of use 3.5 years, mean age at implantation 5 years. No statistical difference, and I think that's important to underline, no statistical difference between groups on these variables. No morphological difference between cortical potential in normal cochlea and cochlear malformation. The right eye cochlear potential, amplitude in cochlear malformation. Very small difference. In every children with the cochlear malformation require more change for simulation. This is the most important difference, because to have the same cortical potential, you have to use a high level of stimulation. In conclusion, preliminary results: possible to record the cortical potential in all children, 100% success. Tricks: avoid children movements, keep children busy during recording with mood, video, cartoon. Try different stimulating cochlear electrodes. No difference in cochlear potential morphology in children with normal cochlea and cochlear malformation. Auditory pathway in these 2 groups lead to the activation of the same brain generators in the auditory cortex. In average possible high charge need for MCL in cochlear malformation due to the electron-neural interface maybe, or nerve pathology. So this is the results that we have had with, in our experience with the different kind of malformation. You can see the best results, of course, is with a larger vestibular aqueduct, and the worst is in the partition incomplete type 3 in the common cavity. All subjects were evaluated before and after surgery by the link sounds test and auditory perception test battery. Thank you so much for your attention. I invite all of you to this meeting that we organized in 2025 in Napoli about the childhood deafness. Thank you so much.
Thank you very much for this in-depth information, and it's really very important information, and to squeeze it in little time, I know it's a hard job, but you did it perfectly. Now, my colleague, Professor Dr. Nasreen Saeed, Professor of Audiovestibular Medicine at Ain Shams University, and she's giving a talk about the implant challenges in cochlear implant children with inner ear malformations. Please, it's 10 minutes and proceed.
Okay, good afternoon. I'm happy to be here, and thank you, Dr. Nadia, for introducing me. I will present audiological challenges in cochlear implant patients with inner ear malformations. This will be based on data collected between 2012 and 19 in King Fahd University Hospital in Dammam, Saudi Arabia. We had 35% of them with inner ear malformations, most of them having either Mondini or IP2, and we had 9 patients with IP1. This data was published in 2023, and I will present 2 more cases, one with IP3 implanted bilaterally and another patient with hypoplastic cochlear nerve. So if we talk about the preoperative challenges, those patients with inner ear malformations had high percentage of positive family history, but this was common in Saudi Arabia, even in normal inner ear subjects. We had significantly higher percentage of patients with inner ear malformations showing progressive hearing loss relative to normal inner ear group. The rate of progression to become profound hearing loss and candidates for implantation was very fast for Mondini. It was the fastest progression. Many of them progressed within less than 1 year, and for most of other anomalies, they progressed in the first 1 to 2 years. So this fast rate of progression highlights the importance of doing close follow-up to discover the drop of hearing as early as possible. As for us as an audiologist, we have to know that this patient is having anomaly, so radiology results are very important to us. Regarding the electrodes we use for those patients, we prefer to use the straight electrodes, even in patients with short modulus, and we use the form electrode for IP1 and IP3 cases because of the high possibility of developing gusher. What happens if we use a modular hugging electrode in a short modulus patient? We could have a problem of tip foldover. So this highlights the importance of the intraoperative assessment. We have to do some testing to detect this problem, and it is preferable to do intraoperative X-ray. So straight electrodes are preferable, especially, of course, for patients with no modulus, and also for patients with short modulus. And intraoperative assessment is very critical for them. Now we go to the challenges that we met in intraoperatively. Commonly, we use the ECAP for assessment of the auditory nerve response. We measure the threshold, the slope, and the spread of excitation test sometimes. So we got less prevalence of ECAP recording in all of the channels. Many of the patients with inner ear malformations showed absent responses in a big number of channels. And this was very high percentage relative to patients with normal inner ear, especially in the patients with IP1. We couldn't record the ECAP except from few number of channels. Another important point is the waveform morphology of the ECAP. This is an example of normal waveform, single peaked clear response. However, if we look to the data of inner ear malformations, we got high percentage of broad peak responses, especially patients with IP1 and IP3. Also, we noticed elevated ECAP thresholds and lower slope of amplitude growth function, and all these findings reflect the less number of spiral ganglia. This is example from our IP3 patients. Intraoperative challenges here include first is the possibility of implanting the electrode in the internal auditory canal. This can be detected by the Volt matrix test here. It showed abnormal results when we did X-ray. The electrode was in the internal auditory canal. The position of the electrode was corrected, and the result now is normal, showing normal responses. Also, we have another challenge intraoperatively that we couldn't elicit the ECAP responses from all of the electrodes intraoperatively. So if we couldn't elicit ECAP, we have to change the parameters of the ECAP to get more clear responses, or better to use alternative way like ESRT or electric ABR, and X-ray is usually recommended in patients with inner ear malformations, especially the severe malformations. Now the challenges in programming. Some of the patients with severe anomalies like the IP1 or IP3, we had elevated T levels and narrow dynamic range for those patients. And also we may have extracochlear stimulation like facial nerve stimulation, and this was common in IP1 and IP3. This is example for the IP3 patient with facial nerve stimulation, and this was even at low level by stimulating any of the electrodes. So we used the triphasic pulse, and this helped to solve the problem of facial stimulation. This is another example from our patients, one with hypoplastic cochlear nerve. She had elevated T and C levels, narrow dynamic range, in addition to facial stimulation. We used a very wide pulse width and a very low rate of stimulation to be able to do mapping for her and to get clear responses from this child. Now we go to the post-operative performance. The results of our patients were comparable to normal inner ear subjects, except for IP1. They showed the lowest aided thresholds and the lowest speech discrimination. When we analyzed the data for IP1 patients, we noticed that some of them had good or even excellent speech discrimination scores in spite of the IP1 anomaly. Patient number 9, this was an excellent patient having excellent discrimination in the right ear that was first implanted, and in the second ear that was implanted after 4 years interval. So as we see, this severe anomaly give comparable results to patients with normal inner ear. We tried to correlate the data of ECAP intraoperatively to the speech performance, and we found that patients with highest speech discrimination scores post-operatively had the better ECAP responses than patients with lower discrimination scores. So to conclude, in spite of the challenges, inner ear malformations are not contraindication for implantation, and they can give comparable results to patients with normal inner ear. Thank you.
Thank you, Professor Nasreen. It was very important, and I do think it has a lot of tips to go through. Now I welcome my colleague, Professor Lubna Al-Fiqi, the head of the ENT department at Ain Shams University. And now she's going to give us her experience about the children with syndromic hearing loss and CI. Please go.
Good afternoon, everyone. Thank you, Dr. Nadia. My talk will be in continuation with the same previous presentations, talking about the cochlear implant in syndromic children. We all know that we have a large number of syndromes with hearing impairment, either primary hearing impairment due to the syndrome itself, or sometimes accompanied by secondary syndromes, differently as albinism. The signs of some syndrome are basically visible, especially in the craniofacial area. So we can have the heterochromia, the hemifacial microsomia, which is a spot diagnosis, of course. But some signs of syndromes are not apparent and pass unnoticed, and these are the more dangerous syndrome that we go. We had a long list of questions regarding the patient that we have in our program with syndrome. We wanted to know the commonest syndrome, which one with the incidence of inner ear malformation, and what are the difficulties and how to manage. So along 6 years, we gathered around 1,000 cases, and we found that the syndromic cases were about 4.3%, about 44 cases. Mostly they were prelingual children less than 5 years, except for a couple of cases which were postlingual. Of course, we had some cases of consanguinity, about 36%, and we found actually very strange things, beginning with 10 syndromes were noted. The 2/3 of them were basically JLN and Waardenburg syndrome. We never thought that it was that common in our population. And followed by the rest of the syndromes, keratosis, ichthyosis, deafness, albino, Charge, Usher, and even the rare Hatch syndrome. Regarding the inner ear malformation, in these syndromic cases, we found only 9 cases with inner ear malformation, which constitute about 20%, which is a great percent in these cases. Basically, IP2 was the most common malformation, which is the least, as we say, as we heard just from Professor, from the first presenter. So it was basically very easy to operate on them and have a normal or near normal outcome, as Professor Nesreen showed us. Sometimes we had the middle ear malformation in the rare Treacher-Collins syndrome that present not only with conductive, but basically with severe, profound hearing loss. The most common or most severe syndrome is the Charge syndrome, and we have a case of extreme Charge syndrome with cochlear hypoplasia 2 and 3, and even it has on one side a total cochlear aplasia, which was much more surgically accessible, but having no nerve, of course, it contraindicates the implantation. And on the other side, which has a normal nerve, it has the facial nerve passing over the round window, which necessitated actually some modification during surgery. Coming to the most common syndromes that we saw, it's Jervell-Lange-Nielsen syndrome, long QT syndrome. Basically, it's an undiagnosed pathology with a silent danger. Only one had a preoperative diagnosis. The rest were diagnosed as petit mal epilepsy and were receiving treatment for that. No inner ear anomaly in any case of this case. We learned a lot and we have a lot of lessons from the EJLN, because if not diagnosed preoperatively, you might lose your patient on table because of the cardiac arrest if you are not prepared for it. Of course, ECG is a routine in all cases of those children, which is not common to do in ECG for children preoperative, but not in cases of cochlear implant. And of course, you have to check that with your anesthesiologist, and your anesthesiologist must know about this syndrome much more than you do. And we have to be ready with DC shock, and we avoid the adrenaline or any cause that cause tachycardia. And of course, once diagnosed preoperatively by the ECG, we begin the medical treatment even at the night of the surgery. It makes a hell of a difference for this patient. We have to counsel the parent and send to cardiologists for further treatment and follow-up, because some of them can actually need some pacemaker later on. One of the most important things is that you have to inform your audiologist, because arrest can be triggered by first fitting, even if the patient is under medical treatment. And even when you increase the fitting or the CNT level, some patients have attacks of bradycardia and even up to arrest in this case. The second syndrome was the Waardenburg syndrome. It's a very easily diagnosed either by the patient itself or by his relatives, who are basically normal in the hearing. We found 14 cases, which is about a third of the cases, and we found that the type 2 is the most common cause, and there were no inner ear anomaly in this case. The same regarding the keratosis, ichthyosis, deafness syndrome. Of course, they have a hearing loss, skin abnormality, and also eye problem. So we have two problems in these cases. Of course, flap problems may occur and exclusion can occur even on the long term because they use medical treatment and basically local lotions all over the body, and part of it is the skin of the scalp over the device. So we have to have continuous moisturization of the skin. And the other problem is they will develop at any time of their life eye problems. So it's much more better to have a bilateral implantation as early as possible with all the problem that can go of it. Usher syndrome is the most severe, which is Usher syndrome 1, and it has some vestibular problems, as we heard a little bit earlier. It's not always presenting like that with nystagmus. Sometimes it presents with delayed walking, and not even delayed walking. Sometimes it's denied by the parents. So we have to do a fundus evaluation, and the same bilateral implantation is very advised. Regarding Treacher colon, basically they present with external ear and middle ear anomaly. Very rarely they present with bilateral profound hearing loss. And of course, we should abide to the middle ear anomaly that we shift. In this case, it has an IP2, as we said, it's the commonest, but the normal facial nerve coarse, but abnormal middle ear cavity. So you can see the thick chorda tympani in an abnormal position. And of course, the oozer more or less, or a slight gusher with the IP2. However, they can accommodate any type of electrode, but we don't prefer the perimodular. We prefer the lateral wall, and here for the control of the perilimb gusher, we also use the form electrode with the stopper for it. How to diagnose? We have to suspect in every case. Of course, the morphological features are quite clear and you can see them very easily. We have to do a vision examination for any vision affection and presentation in different problems of the eye with the hearing loss, vestibular problem regarding delayed walking, loss of consciousness, and any operation for this patient. Of course, there are a lot of investigation that can be done. Some can be done routinely as the ECG, the fundus examination, but other can be chosen to do at a specific situation. Of course, genetic mapping is the deciding problem, but it's not always available in everywhere. So we have a very wide range of syndromic patients in our cases, and we see more and more every time, and we become more and more acquainted to the difficulties of it. So sometimes the diagnosis is not clear, but we have to expect a cochlear nerve deficiency, inner ear anomaly, facial nerve anomaly, middle ear malformation. We need a lot of collaboration with different specialty and counseling regarding spiral ganglion affection of this patient. Thank you very much.